Hello everyone. In this video, I'll be talking about the anatomy of middle ear and middle ear cleft. So when we say middle ear cleft, actually it includes more than the middle ear. So this is middle ear, but if we include the attic region, the adytus, the antrum, the mastoid air cell system, as well as the eustachian tube, then this whole thing it is called middle ear cleft. So we'll start with the middle ear. Now middle ear it is like a six-sided box. The six sides of the middle ear are the roof, the floor, the anterior wall, the posterior wall, the lateral wall and the medial wall. So in subsequent slides we'll be seeing the details of each wall. And the middle ear it is divided into three parts. So the upper part of the middle ear it is called attic or the epitympanum. The middle part is the mesotympanum and the lowermost part it is the hypotympanum. And sometimes the portion of the middle ear around the eustachian tube it is called protympanum area. But basically middle ear is divided into three parts. So this is here we can see that the part of the middle ear which is opposite to the tympanic membrane, that is the mesotympanum. The part which is above is hypotympanum or attic region, and the part which is below the level of the tympanic membrane, this is the hypotympanum. So as I told you that middle ear is a six-walled box type of structure with a roof, floor, anterior, posterior, lateral and medial wall. So we'll see each wall one by one. So first roof. Roof is formed by the tegment tympani. So this is a schematic representation of the middle ear. Now here the lateral wall has been removed. That is, imagine that the tympanic membrane has been removed. So we can see that this is the roof. It is called tegment tympani and it separates the middle ear from middle cranial fossa. Then this is the floor. As we can see here that it separates the middle ear from the jugular bulb which is below the middle ear. Then the anterior wall. Now this is the anterior wall of the middle ear. Now we see that it separates the middle ear from the internal carotid artery and it has two openings. The upper opening, this one, it is for the tensor tympani muscle and tendon, and the lower opening, this it is for the eustachian tube. So eustachian tube opens into the anterior wall of the middle ear through this opening. Now the posterior wall. So posterior wall has many important structures. One of them is pyramid. Pyramid is the bony projection where the stapedius tendon, it appears to get attached to the neck of the stapes. So it gives attachment to the stapedius tendon, pyramid. Then adytus. Adytus is the opening through which attic communicates with the antrum. So I'll show you the figure also. So basically adytus, it is an opening from where the middle ear attic part, that is epitympanic part, communicates with the antrum. Then facial recess. It is also called posterior sinus. It is a depression present in the posterior wall which is lateral to the pyramid. And this is the site for posterior tympanotomy. A posterior tympanotomy approach is used in many surgeries, for example, cochlear implant surgery. So we want to enter the middle ear through posterior tympanotomy approach, and it is also called facial recess approach. So here we can see this is the posterior wall. So this is the pyramid. It's a bony projection which gives attachment to the stapedius tendon. This is the adytus from where the attic region, it will communicate with the mastoid antrum which will be present here. So this is adytus, and this area, that is lateral to the pyramid, this area is the facial recess or posterior sinus from which by posterior tympanotomy we can gain access to the middle ear from this area. So this is facial recess area lateral to the pyramid. Now moving to the medial wall. So it is formed by the labyrinth and promontory. It is a bulge over the medial wall of the middle ear, which is because of the basal coil of the cochlea. Then there is an opening in the medial wall, which is oval window, which is for the stapes footplate. Another window, it is round window, also called fenestrae cochleae, which is opening for scala tympani. Then there will be a canal for the seventh cranial nerve, that is fallopian canal or facial canal, which is located above the oval window. And then there is a processus cochleariformis, which is again a hook-like projection present anterior to the oval window. The tendon of the tensor tympani turns here to get attached to the neck of malleus. So we'll see the anatomy of the medial wall in a figure in next slide. Now this cochleariformis process, it also marks the genu of the cranial nerve 7th. Hence it is an important surgical landmark in the facial nerve surgery. Then sinus tympani. It is a deep recess medial to the pyramid. So earlier we saw that facial recess was present lateral to the pyramid, but another recess which is present medial to the pyramid, it is the sinus tympani, and it is part of the medial wall, and it is bounded by ponticulus above and subiculum below. So we can see this is the medial wall of the middle ear, and this is a bulge in the medial wall, which is called promontory. This is because of the bulge. It is a bulge of the basal turn of cochlea. Then we can see the two openings here. One is the above opening, it is the oval window. Here the footplate stapes, footplate of the stapes gets attached and it opens into the scala vestibuli. The lower opening, it is a round window which opens into the scala tympani. Then above the oval window, there is a fallopian bony canal, which is the facial canal which bears the facial nerve, and it is present between the bulge of the lateral semicircular canal above and the oval window below. Then, as I told you in the posterior wall, this was the facial recess. So a similar recess medial to the pyramid, that is medial to the pyramid. Here somewhere there will be the sinus tympani. The clinical importance is that this is one of the areas where cholesteatoma may be left behind during surgery. So this is a hidden area of cholesteatoma, we can say. Anterior to the oval window, here there will be a bony hook-like projection which is processus cochleariformis. The tensor tympani tendon, it enters from the anterior wall, then it turns around the processus cochleariformis, and then it attaches to the neck of malleus. Now the lateral wall. So we know that lateral wall, this will be the lateral wall, and some part of the lateral wall, it is formed by the tympanic membrane, and another part, it is a bony lateral attic wall or outer attic wall, which is called scutum. So this part is scutum and this part is tympanic membrane. So both these part form the lateral wall of the middle ear. Now the details of the tympanic membrane I have already discussed in my video on anatomy of the external ear. Now mastoid antrum. So mastoid antrum, it is the largest air cell, and it is a McEwan's triangle is there, which is present over the temporal bone. It is also called the suprameatal triangle, which is basically landmark to locate the mastoid antrum during the mastoid surgery. So in any surgery where we have to open the mastoid antrum, for example cortical mastoidectomy, then we start drilling at this area, that is McEwan's triangle. It is also known as suprameatal triangle. Now there are three types of mastoid air cells based on pneumatization. So sometimes mastoid cells are well pneumatized, or they are also known as cellular. They are large and well pneumatized mastoid air cells. Normally people have pneumatized mastoid air cells. Then there can be sclerotic or acellular mastoid air cells, where the cells are absent and the whole area is sclerosed. So normally sclerosis is present in a diseased mastoid, but in around 20% of individuals, the normal mastoids are also sclerotic. And the third type, it is diploitic, that is cells will be small in number and they will be small in size also. That is somewhere between well pneumatized and sclerotic, there is diploitic. So this is the method of classifying the mastoid air cells based on pneumatization. Another method of classifying the mastoid air cells is depending on the area in which they are present. For example, the mastoid air cells which are present near the eustachian tube area, they are known as peritubal. Then if they are present near the petrous apex, they are known as petrous apex cells. Then near the zygomatic, they are known as zygomatic cells. Then if they are present in the squamosal part of the temporal bone, they are known as squamosal cell. Near the synodural angle or the satellis angle, they are known as synodural angle cells. Perisinus cells, then mastoid tip cells, then retrofacial behind the facial canal, and periantral around the mastoid antrum. So depending on the position also, we can classify the mastoid air cells. Now, corner septum. So during development, what happens? The superficial squamosal part and the deep petrosal part of the temporal bone, during development they fuse, but sometimes there is a persistent of a bony plate between these two parts, that is superficial squamosal and deep petrosal part. There is a persistence of this bony plate which is called corner septum. The clinical importance is that when we start drilling from superficial and when we want to reach the antrum, but when we come across this corner septum, we think that we have opened the antrum and actually the disease will be present. So we will not be able to remove the disease unless we remove the corner septum. So this is the clinical importance of corner septum. It is a persistent bony plate between the squamous and the petrous part of the temporal bone. So basically we can say it's a developmental anomaly. Now ossicles, they are also present in the middle ear. So there are three ossicles as we know: malleus, incus and stapes. Malleus is hammer-like, incus is anvil-like and stapes stirrup-like. So if we see each ossicle in detail, so first malleus, malleus has head, then it has an articular process, articular facet rather, which articulates with the incus to form the malleoinguinal joint. Then this is the neck of the malleus. This is the anterior process of the malleus. This is the lateral process of the malleus. So during otoscopic examination, we see this process. Now from here, the anterior and the posterior malleolar folds they arise. Then this is the handle of the malleus, or also called the manubrium of the malleus, and this is the lowermost part which forms the umbo, which is seen on the tympanic membrane. Then moving on to the incus. So incus, again it is an facet to form a joint with the malleus. Then this is the body of the incus. This is the short process. This is the long process of incus, and the lowermost part is the lenticular process of incus. Now, clinical importance of long process is that it has a very limited blood supply. So during any ear pathology like CSOM, the long process of incus is the first ossicle to get eroded. Then the third ossicle is the stapes. Stapes is the smallest bone of our body. Stapes has head. It has true crura, the anterior and the posterior crura, and this is the foot plate. This foot plate, it is attached to the oval window which separates the middle ear from scala vestibuli. Now intratympanic muscles. So there are two muscles present in the middle ear. One is the tensor tympani, as we saw, which enters the middle ear from the anterior wall. It tenses the tympanic membrane. So as the name suggests, it tenses the tympanic membrane. It is developed from the first arch and it is supplied by the third branch of the trigeminal nerve. So it will enter the middle ear from the anterior wall above the opening of the eustachian tube. It will get attached to the processus cochlear formis in the medial wall, and then it will turn around and attach to the neck of the malleus. Another muscle in the middle ear, it is the stapedius muscle, as we can see here. So it attaches to the neck of the stapes. So it arises from the pyramid in the posterior wall and then it gets attachment to the neck of the stapes. The importance is it dampens the very loud sounds. So whenever the ear is exposed to the loud sound, so there is contraction of the stapedius muscle which fixes the stapes against the stapes foot plate. It fixes the stapes, so there is no movement and the loud sound is not transmitted to the inner ear, so it does not cause acoustic damage. So basically stapedial reflex, it is a protective reflex. The stapedius muscle develops from the second arch and it is supplied by the seventh cranial nerve, that is facial nerve. The nerve supply of the middle ear. So middle ear is supplied by the tympanic plexus. So plexus is a group of nerves, as we can see here. This is the tympanic plexus. So this is formed by the tympanic branch of the glossopharyngeal nerve, that is Jacobson's nerve, and also from the sympathetic fibers from the plexus around the internal carotid artery. So glossopharyngeal nerve and this plexus around the internal carotid artery, it forms this tympanic plexus. This tympanic plexus lies on promontory, and it also carries secretomotor fibers for the parotid gland. Thank you.